Good morning, everyone, and thank you for organizers who invited me. And this is a really great pleasure, my pleasure to be with you. Even I have been already visited your country and your town, and I enjoyed a lot. So we will talk about, and I think that you already talked about the antimicrobial use in hospitals, but this is what we have done in this point prevalence study in this region. So I would like to share that results with you. So the overuse and misuse of antimicrobial agents, we know a lot about that, and it's a problem that well recognized as one of the key drivers of emerging antimicrobial resistance, with antimicrobial, of course, consumption projected to rise further globally. Drug resistance infections have been estimated to account for 700,000 deaths per year globally, accumulating to 10 million by 2050, higher than cancer and diabetes combined. So really big problem. A few days ago, I found this new CDC analysis reveals continued increases in healthcare-associated infection in U.S. hospitals during 2021, the second year of COVID pandemic. These increases corresponded with periods of high COVID-19 hospitalization and were especially elevated during the first and third quarters of 2021. Data from CDC National Healthcare Safety Network show significantly higher incidence in central line-associated bloodstream infection, catheter-associated urinary tract infection, also ventilator-associated events, and MRSA bacteremia. Also, the WHO recently introduced AWARE antibiotic classification framework based on accessibilities versus antimicrobial resistance potential, and is a useful metric to provide an indication of the appropriateness of antibiotic consumption. However, recent assessment of antibiotic consumption data from 76 countries in 2015 found the global per capita consumption of water antibiotics increased by 91% compared with an increase of 26.2% in assessed antibiotics. And what is the biggest problem is that in the countries, low and middle income countries, that increases was desperate 165% compared with in high income countries, which is less than 30%. The general overuse of antimicrobials has been worsened by COVID pandemic, with concerns with differential diagnosis between infections such as tuberculosis and bacterial upper respiratory tract infections from influenza, cold, fever, and COVID. There is a concern that these unnecessary antibiotic will further drive antibiotic use will further drive antimicrobial resistance. Published evidence of bacterial and fungal infections in patients with COVID-19 suggests that the incidence of this infection is low, but a large number of patients receives antibiotics upon admission to hospital or during hospitalization. A review of NICE studies reporting bacterial co-infection in COVID-19 cases were 64 of 806, which is 8% cases of bacterial and fungal co-infection which were found. Okay, so published evidence of bacterial and fungal infection in patients with COVID-19 suggests that the incidence of this infection is low, but a large number of patients receives antibiotics upon admission to hospital or during hospitalization. A review of 9 studies reporting bacterial co-infections in COVID-19 cases also showed that 62 of 806, which means 8% of cases of bacterial fungal co-infection, were reported. Usage of broad-spectrum antimicrobial therapy was widely reported, with 72% of COVID cases receiving antimicrobial therapy. So, also from Netherlands, our colleagues reported, did the studies and systematic reviews and reported the use of antimicrobials in hospitals in COVID patients in about of 39 to 74% of patients. The study from Scottish was also interested because about 38% of COVID patients were identified receiving antibiotic therapy, and the prevalence of antibiotic prescribing of this way was 45%, which was higher than reported in prevalence estimate from 2 Scottish PPS studies of antibiotic prescribing in acute adult patients, which has been done in 2016 when was 36 and 33 in 2011. This is also not unexpected, as the present PPS was restricted to the patients carried in hospital units designated to COVID-19 cases in the midst of the pandemic. Prescribing appears to vary between different countries and hospitals. To review, examining antimicrobial use in COVID patients reported higher overall antimicrobial uses. Also in study from China, majority of patients, about 58%, received intravenous antibiotic therapy. From New York, USA hospitals, a study confirms widespread antibiotic use in most hospitalized COVID-19 patients, but less than 5% experience co-infections. When first reported in Wuhan, that was in December 2019, more than 90% of hospitalized patients with COVID received antibiotics with little supporting evidence of associated bacterial infection. All of this global PPS study which worked, and we also used, the first one of this study was prepared and developed by University of Antwerp, and I use this opportunity just to mention that this PPS launched worldwide in 2015 and repeated in 2017, and now since 2018 available on 4 monthly basis, and the global PPS has been used in more than 70 different hospitals from over 70 different countries, and this is, I think, very useful for countries, low and middle income countries. So we conducted an international multi-center point prevalence study, the first point prevalence study in this region, to collect comprehensive data on the characteristics and differences of antibiotic and antifungal prescribing in hospitalized patients with COVID-19. Due to its point prevalence design, it can also provide a snapshot of practice in a specific time window during the pandemic. Our multi-center point prevalence study took place from 11th February to 5th of April 2021, in 7 tertiary university hospitals in 4 countries, Croatia, Italy, Serbia, and Slovenia. It was conducted in medical wards and in intensive care units where patients with confirmed COVID-19 were cared for. Each COVID-19 ward was audited once, and on a single day, all patients 18 years of age and older with confirmed COVID-19 who were hospitalized on the ward at 8 o'clock in the morning and were at the time receiving systematic antimicrobial therapy were included in the study. 2 forms were used for data collection. The first ward form was used to collect information about number of beds, number of patients, number of ventilated patients on the ward, which is denominator data. And the second, which was patients forms, were used for inpatients receiving antimicrobial therapy. For each patient, patient's characteristic, days of hospitalization, days of antimicrobial therapy, indication for antibiotic or antifungal, use, type of antimicrobial and its dosage, biomarker levels and radiological findings, use of supplemental oxygen, and treatment of COVID were recorded. Antibiotic and antifungal treatment was classified as either prophylactic, medical or surgical, or therapeutical, empirical, or target. In case of target treatment, microbiological data were also collected. So the results are here in 7 tertiary university hospitals in Croatia, Italy, Serbia, and Slovenia. Almost 100, actually 988 COVID patients were enrolled, and 521 were receiving antibiotics or antifungals, which is almost the same what we find in literature. That was 52.7%, and across the hospital that the range was 33 to 86% on the day of the study. The percentages of patients receiving antibiotic, as I said, varied between hospitals and was higher in intensive care units. It was ranged between 54 to 100. Then in medical wards, where it was ranged between 14 to 93%. Approximately 2/3 of patients received 1 antibiotic or antifungal. 2 antibiotics received 26%, and 3 and more antibiotics received 8% of patients. It is worth noting that the period of interest in our study was not the first way, when uncertainty and common practice were in favor of antibiotic prescribing. We are talking about February to April 2021. And we all of these countries and hospitals had already prepared the protocols for treatment, and there were no recommendation for usage antibiotic for every single patient. The majority of patients received antibiotics, and within 48 hours of admission, 62% of them. A total of 743 antibiotics and antifungals was prescribed. Their most common use was empirical, and pneumonia was the main indication for starting the treatment. And this is shown through the hospitals, through the countries, and going through the assess, watch, and reserve antibiotics. As we saw on this graph, we see that what is reserved is in a red line, that in Serbia and also in Italy, reserve antibiotics used much more than in another countries, but the differences in prescribing in these different countries may be explained with total consumption of antimicrobial agents in defined daily doses per 1,000 inhabitants per day in 2019, when we had this result that in Croatia it was 19, almost 19, in Italy almost 22, in Slovenia 13, and in Serbia 28.6. With watch category antibiotics accounting for 30% of all prescribed antibiotics in Slovenia and around 40% in other 3 countries. So in some hospitals in our study, broad-spectrum antibiotic was initiated admission, while in others a more prudent approach to antimicrobial therapy was taken. In accordance with local antimicrobial susceptibilities, hospitals in Serbia and Italy prescribe antibiotics from watch and reserve list of a fair classification more frequently. As I am from Serbia and working in University Clinical Center, and I did this study in my clinical center, the results, if we look only at Serbia, my hospital, and the other one, University Clinical Center Kragujevac, we observed high levels of parenteral and empirical use of broad-spectrum antibiotics and inadequate performance of key quality indicators of prescribing. Despite important progress in antimicrobial stewardship, supported by national policies, the study findings from our hospital highlighted the need to strengthen antimicrobial stewardship to increase use of narrow-spectrum antibiotics through culture-guided, targeted treatment and hospital-guide compliance. As a conclusion, we could say the data from our study showed that early empirical use of broad-spectrum antibiotics is common in COVID patients, and that the pattern of antimicrobial use varies from hospital to hospital. The widespread use of last-line antibiotics identified in some settings, combined with the heavy burden of hospitalized COVID-19 patients, may lead to substantial increase in antimicrobial resistance. Antibiotics should not be routinely prescribed on admission to patients without evidence of bacterial co-infection. However, especially in critically ill patients, distinguishing between severe COVID-19 and bacterial co-infection can be challenging. Microbiological sampling in these patients should be encouraged to guide or to discontinuate or to stop antimicrobial treatment based on its results. Also, the role of biomarkers such as procalcitonin may be value levels of procalcitonin below 0.1 microgram per liter have been shown to have a negative predictive value. Unfortunately, the median value of procalcitonin in our study was 0.2 microgram per liter, suggested that many prescribed antimicrobials were probably unnecessary. Further research is needed to understand the complex drivers of antibiotic prescribing and to develop context-specific and feasible quality improvement strategies to strengthen existing antimicrobial progress. Thank you for your attention, and sorry for this not be so available to see all this as well.
We'd like